A very good morning to everyone. So today we will be continuing with our dental caries lecture. In this lecture, we'll be studying about risk assessment and management. So for risk assessment, we'll be covering or studying about all the biological, behavioral, and environmental factors that directly increase the probability of caries. And we'll also be studying about the comprehensive management of dental caries of both the lesion and the disease, and about non-invasive and invasive and preventive treatments for dental caries. From the previous lecture, we've understood that the transformation of dental caries from a physiologic process to a pathology is not a sudden crossover. It happens over a period of time and is affected by numerous variables. So, when we talk about managing caries, we have to direct our treatment towards the pathologic factors and also towards the demineralization remineralization cycle imbalance at the tooth level. And to treat these two things, we can either use non-invasive methods or invasive treatment strategies. We'll be studying about them in detail later. So historically, surgical model of caries management was used, and it involved biomechanical removal of carious lesions and restorations. The management of caries by a surgical model always consisted of waiting until cavitations were detected and then just treating them with restorations. It only dealt with the end result of the disease, and it did not address the etiology or the reason for caries for each individual patient. Now, since the surgical model alone was not enough and was not good enough, an evidence-based system was developed, which we now follow, and it is the medical model of caries risk assessment and management. So this particular model involves looking at each patient's unique set of pathologic factors and protective factors. It is a patient-centered intervention. It provides individual evaluation, and on top of that, it also assesses the patient's risk for developing future disease. Risk assessment primarily intends to identify individuals who are prone to disease. So, caries risk assessment can be comprehended as two models, namely the risk model and the prediction model. So, a risk model identifies factors of the dental caries disease, causative factors of the dental caries disease, and the prediction model identifies the patient who is at high risk for the disease. So the clinician must gather all appropriate data from the patient interview and his clinical examination to formulate an individualized caries risk assessment. Now, all said and done, we already know that caries is a complex multifactorial disease with no single risk factor which is highly predictive of future caries. But we do a caries risk assessment uh, just to inform the patient and to also know ourselves what interventions might lower the patient's caries risk in the future, which of course is the ultimate goal of caries management in a medical model. So we identify risk factors. Risk factors may be any environmental, behavioral, biologic factors which directly increases the probability that a disease will occur. But all said and done, removal of a risk factor also does not guarantee that it will always result in the disease process being halted. There are some risk factors which are modifiable, like sucrose intake, fluoride exposure. You can always do a dietary analysis, ask the patient to reduce sucrose intake, give them topical fluorides. But there are certain risk factors which are non-modifiable, that is xerostomia, which might occur because of as a result of medication that the patient is already taking for some kind of underlying systemic disease. Caries management by risk assessment is the standard of care in caries management, and one of the most widely used systems in the United States is caries management by risk assessment. Now, caries risk assessment is only effective if it is used in conjunction with a corresponding caries management program also. So the caries prevention or management program should comprise a menu of preventive therapies and interventions that should be recommended on the basis of level of caries risk. This is how both caries risk assessment and caries management work together. An ideal caries risk model should always be inexpensive, easy to use, and highly accurate. And to develop an individualized caries risk assessment, the clinician should take a detailed patient history, do a detailed clinical examination to identify the risk factors, the risk indicators, and also assess the caries lesion activity. Now, identification of risk factors are mainly identification of factors that indicate that the patient is at a high risk of developing caries in the future. So, there are health history factors, and then there are clinical examination findings which are associated with increased caries risk. With health history factors that are associated with increased caries risk, it is history factors that such as age, that is, it is either childhood, adolescence, or very old age, where high risk of caries is seen. No fluoride in public water supply, no fluoride in toothpaste, increased alcohol and smoking, chronic illness and debilitating condition, and consuming medication that reduces salivary flow. These are all health history factors associated with increased caries risk. On clinical examination, findings that might be related with increased caries risk can be a sick appearance of the sick general appearance of the patient, inability or unwillingness to comply with the dietary and oral hygiene instructions owing to their mental or physical disability, dry or glossy mucosa suggesting decreased salivary flow, already present active caries lesion, high plaque scores, puffy, swollen, inflamed gingiva, which easily bleeds on probing, and already existing large number of restorations. So these are all different findings that we encounter while taking the patient's interview and also while doing the clinical examination that are clearly associated with increased caries risk. In addition to all the risk factors that were discussed for adults and adolescents in the previous slide, there are certain factors and indicators that have to be considered for children under 6 years of age. So presence of active caries lesion in the primary caregiver, feeding on demand past 1 year of age, bedtime bottle or sippy cup with anything other than water, no supervised brushing, and severe enamel hypoplasia are all risk factors which place kids under 6 years of age at increased risk of developing caries. So identification of risk indicators is an existing sign of the disease process, and there are clinical observations and detection modalities which are used to identify risk level status of the patient. Now, risk indicators can classify a patient as at risk or high risk, although this is very subjective and it changes from clinician to clinician. But so to say, visible cavitations in patent fissures or in proximal surface areas of the teeth, brown spots, active white spots, cavitated lesions in free smooth surfaces, restorations placed in the past 3 years. These are all risk indicators that classify a patient as at risk or high risk. Now, components that need to be analyzed for caries risk assessment are, firstly, we need to do a dietary analysis. That is, the patient needs to be inquired about the intake of sugar, candy, lozenges, acidic beverages, frequency of snacking. One very important thing to be noted is that caries activity is very strongly stimulated by frequency of sucrose intake rather than the quantity of sucrose intake. We inquire about acidic beverages because They increase the risk of developing caries by providing energy to acidogenic and acidic bacteria and also by altering the pH of the biofilm. Second is the dental clinical analysis or the dental examination. This determines the risk indicators more than the risk factors. And indicators are white spot lesions, visible cavitated caries lesions, or brown spots. Bacterial biofilm analysis can be done. These are supplementary tests like the S mutants count, lactobacilli count, ATP activity of the biofilm bacteria. And as a part of salivary analysis, we can analyze the salivary flow rate, the salivary buffering capacity, and the salivary pH. So one of the important roles of caries risk assessment in the management of caries is to determine the current caries lesion activity. So one needs to include or document whether there are active caries lesions. Active caries lesions are the ones which are progressing. Inactive caries lesions are the non-progressing dormant lesions. Inactive lesions usually mineralize over time and they do not require operative interventions. Active caries lesions are progressing, so they require tooth preparation followed by restoration. Moving on to the clinical considerations in caries prevention. Now, the effectiveness of a patient's immune system depends on his overall health status. So, patients undergoing radiation or chemotherapy have significantly decreased immunocompetence and also reduced salivary rate. So, they are at risk of increased caries. Medically compromised patients should be examined for changes in the plaque index, salivary flow, oral mucosa, gingiva, and teeth. Decreased saliva flow is very common during acute and chronic systemic illnesses because of the underlying medications that they're taking. And ambulatory patients with chronic illnesses with reduced dexterity, who often take multiple medications, always and you they suffer from reduced salivary flow, which results in increased plaque and increased root caries cases. The second is the diet. So, like we've discussed earlier, dietary analysis needs to be done for each patient. So, we need to inquire about the frequency and quantity of fermentable carbohydrate intake, acidic beverages intake, sugar, candies, lozenges, all of this. The entire goal of dietary counseling is to identify the source of sucrose and acidic beverage in the diet and then to reduce the frequency of ingestion. So this is because dietary sucrose has two detrimental effects. Frequent ingestion has a stronger potential, results in stronger potential for colonization by mutant streptococci, and often on frequent ingestion, the mature plaque which is already present rapidly metabolizes it into organic acid. So if you see rampant caries in interproximal areas, it means that diet is the main factor. So strict diet analysis or dietary changes need to be made. And rampant caries in cervical and interproximal areas clearly indicate that diet and hygiene are the causative factors. For very high risk patients, diet analysis is always recommended, and the dietary analysis or documentation is done over a period of 4 days, out of which 2 days should be the weekends. One of the most important factors in caries prevention is oral hygiene. One thing we need to understand is biofilm-free tooth surfaces don't decay. So daily removal of plaque by dental flossing, by toothbrushing and rinsing is the best measure for preventing caries and periodontal diseases. So this mechanical plaque removal can be done by brushing or by flossing, or or plaque control can also be done by topical antibiotics, although brushing and flossing is the preferred method. Firstly, because it does not eliminate the normal oral flora, and secondly, because it does not predispose the host to infection by antibiotic resistant pathogens like Candida albicans. Patients with good plaque control have a high percentage of S. sanguis and S. mitis, And contrary to the popular belief, the purpose of routine flossing is not to remove debris from interproximal space, but rather it is for the removal of bacterial plaque from proximal tooth surfaces. Now, this is a pictorial demonstration of the braced technique of flossing. So the first photo, you can see how the fingers are holding the floss. In the second photo, the index finger is holding the floss in the embrasure and the other hand is pressing the floss diagonally through the contact. In the third photo, you can see that slight anterior pressure has been applied to the floss so that it moves along the distal surface of the tooth, and the floss is moved superiorly and inferiorly over the tooth surface from the inferior side of the contact to the depth of the gingival sulcus. In the fourth photo, you can see that the floss is slightly lifted over the papilla and it has gently been positioned posteriorly to wrap the mesial surface and promote its cleaning. And it is for the mesial surface, although the same superior inferior motion needs to be applied for cleaning. In the fifth photo, you can see the floss is being removed facially through the contact. Now, this is a demonstration of the circular brushing technique. In photo A and B, you can see that a toothbrush has been applied to the facial surface of the tooth at 45 degrees. And there's a double-headed arrow indicating the extent of vibration. The brush head needs to be vibrated for the tips of the bristles to be able to enter the facial embrasures in the gingival sulcus and clean them properly. In figure C, you can see the brush has been applied as depicted in A and B. D is also demonstrating the same circular vibrating motion and the circular vibrating technique for lingual surfaces of mandibular anterior and the most posterior distal surface have been demonstrated in the bottommost pictures. Now, fourth factor in caries prevention is the fluoride exposure. Fluoride in trace amount increases the resistance of tooth structure to demineralization, and especially when it is available during cycles of tooth demineralization, it is a major factor in reducing the caries activity. There are various sources from which an individual can acquire fluoride. It can be fluoridated community water system, fluoride in the diet, fluoride in toothpaste, fluoridated mouth rinses, or professional topical fluoride applications like APF gels and varnishes. Coming on to the mechanism of the action of fluoride, which is very important. Two main mechanisms. First is the precipitation of fluorapatite, second is its antimicrobial property. So, fluorapatite is insoluble precipitate which replaces the soluble salts containing manganese and carbonate, which are lost during demineralization process. This entire exchange process and the incorporation of fluorapatite makes the enamel more acid resistant to further attacks. Second mechanism of action of fluoride is the antimicrobial activity. In low concentration, fluoride ion inhibits the enzymatic production of glucosyl transferase. So glucosyl transferase promotes glucose to form extracellular polysaccharides, and this increases the bacterial adhesion. So intracellular polysaccharide formation also is inhibited by this, therefore preventing the storage of carbohydrates by limiting the microbial metabolism between the host's meals. In high concentration, that is 12,000 ppm, which is used in topical fluoride treatments, the fluoride ion is directly toxic to some oral microorganisms, including mutant streptococcus. So, suppression of growth of MS after a single topical fluoride treatment may last several weeks, and it is also possible to lengthen this suppression greatly by a change in dietary habits, especially by eliminating sucrose, acidic beverages, etc., and by patients' conscientious uh, application of a good oral hygiene program. This is a very brief summary of systemic topical fluoride and different methods of delivery and the concentrations they should have and the amount of caries reduction they result in. The clinician's goal is to choose the most effective combination for each patient. This choice is based on the patient's age, previous caries experience, general health, oral hygiene. For example, children with developing permanent teeth benefit most from systemic fluoride treatment via the public water supply. And in regions without adequate fluoride in water supply, dietary supplementation of fluoride is indicated for children. So the amount of fluoride supplement that needs to be given has to be determined individually, and this is of particular importance in villages especially, which have individual wells, because fluoride content of the well water can vary greatly over just short distances within the village. Fifth is an anti-caries vaccine. Although several prototypes have been tested, at this point, neither the efficacy nor the safety of such a vaccine has been demonstrated. And even so, even if an anti-caries vaccine is developed, there are many concerns that may affect its widespread use. First is its potential side effect. Second is its cost compared to public water fluoridation, which is very cheap. And thirdly, there may be limitations imposed by the governmental regulatory agencies, which may ultimately affect the widespread use of anti-caries vaccine. Now, the next important factor in caries prevention is the sealants. Although fluoride treatment, like we studied earlier, is the most cost-effective way to prevent smooth surface caries, but the best way of preventing pit and fissure caries is by application of sealants. They have basically three important preventive effects. First is obviously because we fill the pit and fissures with sealant, they mechanically seal the pit and fissures. Second is, since the pit and fissures are filled with the sealant, they deny entry to all cariogenic microorganisms. And thirdly, sealants render the pits and fissure easier to cleaning by toothbrush and mastication. Next factors in caries prevention are ACP, CPP, which is amorphous calcium phosphate, and in conjunction with casein phosphopeptide. These are very promising and new remineralizing agents. So CPP is a milk-derived protein that binds to the tooth biofilm and is used to stabilize ACP. There are many products like gums, lozenges, topically applied solutions that contain CPP, ACP, and they show good results also. Next are the probiotics. Fundamental concept of probiotics is to inoculate the oral cavity with bacteria, which will then compete with the cariogenic bacteria and eventually replace them. There are a few commercial products which have been introduced, but their level of efficacy is unknown, and they've shown not very promising results. Lastly, existing restorations. Now, the status of a patient's existing restorations may have a very important bearing on the outcome of their preventive measures and caries treatment, because old restorations that are rough, haven't been polished, serve as very good plaque retentive areas. So they should be smoothened and polished or replaced if needed. Should always look for detection of secondary caries should also be done. Discoloration of enamel adjacent to a previously done restoration should be probed carefully, because it indicates secondary caries. And restoration defects such as overhangs or open proximal contact areas, defective contours which result in food lodgement or improper cleaning need to be corrected, usually either by replacement or by redoing the restoration again. The caries control techniques have to be used along with other preventive measures wherever required. So moving on to the first caries control technique, that is management of pulpal exposure or direct pulp capping. Direct pulp capping is a technique for treating a pulpal exposure with a material that seals over the exposure site and promotes reparative dentin formation. There are two types of pulpal exposure, carious and mechanical. Carious type of exposure occurs as a consequence of infected dentin extending into the pulp. So in these cases, infection has already occurred and removal of the tooth pulp is indicated. Mechanical pulpal exposure is the type of carious exposure that occurs in an area of normal dentin as a result of iatrogenic error, that is, as a misjudgment or as an error that has been committed by the operator. Prognosis of direct pulp capping is good only if the tooth is asymptomatic, the exposure is small, that is less than 0.5 mm. The hemorrhage from the exposure site is easily controlled. The exposure has occurred in a clean, uncontaminated environment, that is, rubber dam was placed in the first place, and the exposure was relatively atraumatic. Second, coming on to partial caries excavation and indirect pulp capping. So it is done for teeth that have large carious lesions but no overt pulpal or periapical pathology. So partial caries excavation or indirect pulp capping are conservative ways of managing such teeth. It has significant benefits, that is, it allows for retention of the tooth through the control phase without root canal therapy, because as soon as the infection goes into the pulp or we start a root canal therapy, the prices of the treatment are exorbitant. So therefore, this is a much more cheaper and a more effective and conservative way of treating large carious lesions with no pulpal periapical pathology. And second, a significant benefit of indirect pulp capping is that it avoids the problem of performing endodontic therapy on a tooth that might be recommended for extraction in the definitive phase of treatment. There are various phases of treatments. That is, there is a control phase. Non-operative and operative treatments are usually completed in three phases: control phase, definitive treatment phase, and then maintenance reassessment phase. So here, some tooth might go for extraction in the definitive phase of treatment. So it's better to just do indirect pulp capping in them. One very important point to be kept in mind is if the tooth is found to be non-vital, or if it has symptoms of irreversible pulpitis, or if it has apical periodontitis of endodontic origin, partial caries excavation and indirect pulp capping are contraindicated in such cases. Lastly, it is the root caries management. Root caries is a pervasive problem in a high percentage of older adults, mostly because of the medications that they take, because a large variety of medications have been known to cause dry mouth or reduction in the salivary flow. So risk factors for root caries include gingival recession, poor oral hygiene, cariogenic diet, presence of multiple restorations of missing teeth, existing caries, xerogenic medications, and compromised salivary flow rates. Primary strategy for prevention of root caries are that one should try to improve the salivary flow rate and increase the buffering capacity. Second is to try to reduce the number of cariogenic bacteria. Third is to reduce the quantity and number of exposures of refined carbohydrates, acidic beverages, etc. And fourth is to attempt to remineralize non-cavitated lesions and prevent new lesions from developing. What we need to understand here is that the critical pH, root caries progresses almost 2 times faster than enamel caries, because the critical pH of dentin is between 6.2 and 6.7, whereas that of enamel is 5.5. So as a result, root dentin will demineralize in very weak acids, and so therefore root caries progresses much more faster than enamel caries. Now, in addition to all the strategies that we discussed for prevention of root caries, additional considerations which need to be considered are the use of powered toothbrush, because it is critical that patients susceptible to root caries practice meticulous oral hygiene. Old age usually results in reduced dexterity, so it is better to use a powered toothbrush. And second is restoring all the root caries lesion with a fluoride releasing material. One very important point to be noted here is that whatever fluoride releasing material we use, be it GIC or whatever it is, The material needs to be reloaded a minimum of 3 times with either fluoride containing toothpaste or by any other fluoride containing product. Only then can it serve as a constant reservoir of uh, fluoride. At the end of this lecture, I would like to tell you again that treatment is not just to target the lesions alone, but to manage the patient in a holistic way to ensure the best oral health for a really long time. So therefore, caries management efforts must be directed at the total patient level, and we have to follow the medical model of treatment.